You got into Harvard Law?
What, like it's hard?
Hey guys, it's Kenya with Adventure Nursing. Today we're going to be talking about endocrine essentials, okay? So this PowerPoint is going to include all the things that you guys need to know for the endocrine system for your NP classes, your NP boards, and if you're about to start clinical and you don't want to look crazy. By the time we're done with this, hopefully you'll be able to understand diagnostic and treatment pearls for common endocrine disorders, recognize red flags and board style questions, apply knowledge to primary care and emergency care settings. So let's get started. Okay guys, today we're going to talk about systemic lupus erythematosus first. So systemic lupus erythematosus, or also known as lupus, is also known as the great pretender or the great mimicker. So lupus is nicknamed the great mimicker because it loves to pretend that it's everything except lupus. One day it's joint pain, the next day it's a rash, then maybe it's rheumatoid arthritis. Spoiler alert, it's typically lupus. Diagnosing systemic lupus erythematosus is not a one-test wonder. To diagnose lupus, we're looking for at least 4 out of the 11 criteria, which are listed in the study guide. One of those criteria is going to be that malar rash. The malar rash is going to be a butterfly-shaped rash across the face, and it's going to spare those nasolabial folds like in the picture. A positive ANA alone does not mean lupus, but it can mean lupus if it is present with 4 out of those 11 symptoms. The ANA test, when it's positive, it's sensitive but not specific. Let's talk about the kidneys. Here's where it gets real. Lupus can go after the kidneys without you even realizing it. That's why lupus nephritis is so scary, because it can cause major damage silently. Lupus and the kidney simplified. Imagine your immune system is your body's personal security team. But in lupus, your security squad goes rogue and starts attacking everything, including your kidneys, which are just minding their own business, filtering your blood. Lupus nephritis means that the kidneys are getting sucker punched while trying to just do their job. Why we screen for lupus nephritis and what specifically we're screening for. We screen because early kidney damage is sneaky, like bruises. You don't feel it until it's too late. What we're checking for specifically is going to be protein in the urine or blood. And then as far as our labs, we're going to be looking at that BUN, creatinine, and our GFR. Check kidney function like it's our ex's Instagram history. Who manages what? The primary care, which is going to be us, the NPs. We're going to monitor the kidneys and keep an eye on the labs. The rheumatologist, however, is going to manage the autoimmune storm that might occur when a patient does have lupus. So boom, let's talk about Cushing's disease. Cushing's disease is what happens when cortisol throws a never-ending party in the body and it gets way out of hand. Some of the red flags to look for with Cushing's disease is that signature moon face and a buffalo hump. No, not the animal, but the hump that's going to be on the back of that patient's neck, and a purple stretch marks that look like they've been photoshopped on. Causes can be outside jobs, like think steroid meds that are used aggressively or too much, or internal drama like the pituitary or adrenal tumors. Diagnosis is going to be some detective work that we have to do. So typically we'll get a 24-hour urine cortisol on these patients and a dexamethasone suppression test to help crack the case. Don't rush to the scanner because labs come first, imaging comes later. Once confirmed, hand a baton to the endocrinologist and they might say, let's cut to the chase, literally with surgery. Addison's disease is what happens when your adrenal glands go on a permanent vacation and stop making cortisol. Worldwide, TB is typically the culprit, because why stop at the lungs when you can mess with everyone's hormones too? The giveaway is going to be hyperpigmentation that makes the palms, lips, and elbows look like they've been dipped in bronzer. To diagnose, look for low cortisol, sky-high ACTH, and grab a chest x-ray to rule out TB's sneaky involvement. Treatment is going to be prednisone and flurcortisone, a dynamic duo to replace what's missing. Watch out for Addisonian crisis. It's a full body meltdown that includes nausea, vomiting, diarrhea, super low blood pressure, dehydration, and serious salt cravings. Fun, but not so fun fact, Addison patients are always in a fight or flight mode. Without the cortisol to back it up, yep, they're literally dying for some stress hormones. Okay, so now let's talk about Pheochromocytoma. It's basically an adrenal medulla tumor that acts like it just drank 5 energy drinks, nonstop, adrenaline and noradrenaline. The classic symptom trifecta is going to be monster headaches, heart racing like you just ran a marathon, and sweat pouring like it's hot yoga. These usually come in 15 to 30 minute surprise attacks. Want proof? Check plasma metanephrines or do a 24-hour urine collection for catecholamines because this tumor doesn't hide quietly. The first line of defense is going to be alpha blockers to calm down the chaos before surgery removes the little hormone factory. Think of Pheochromocytoma as your adrenal gland's rogue espresso machine, constantly brewing up anxiety, palpitations, and sweat, just when you don't need it. All right, guys, let's lock in here because we're going to start talking about the thyroid. The thyroid is something that we're going to see in our clinicals all the time, and you'll definitely see it on your boards. So the thyroid might be tiny, but when it's off, everything feels off. So knowing the basics is crucial. Step 1 in checking for thyroid trouble is a TSH test, aka the gold standard of thyroid screening. A normal TSH lives anywhere between 0.5 and about 5.0. If it steps out of line, we follow up with a free T4 to see what's really going on behind the scenes. High TSH, think hypothyroidism, your thyroid's slacking off. Low TSH, that's hyperthyroidism, your thyroid's in overdrive. Picture TSH as the ultimate helicopter parent, constantly hovering, micromanaging hormones, and just keeping things right. I know I said in the last slide, when your parameters are out of whack, you want to check for a T4, but you'll typically do a T3 and T4 if they're out of whack and the patient is having symptoms. So if a patient is coming in and they have a high TSH, so we're thinking that they have hypothyroidism, if they've gained a bunch of weight and they're having some fatigue and cold intolerance, then we will go ahead and we'll draw that T3, T4. If not, then we're going to recheck in 6 months. So now let's talk about hypothyroidism. Hypothyroidism is an overachieving thyroid that's just not pulling its weight. The number one culprit is going to be Hashimoto's disease. Your immune system mistakenly thinks that your thyroid is the enemy. Symptoms scream slow mode. So things like I just mentioned, fatigue, weight gain, dry skin, and a constant need to bundle up like it's winter, even if it's July. The fix is going to be Synthroid or levothyroxine. So for levothyroxine, we're going to start low and slow, especially with our elderly, because we like their hearts beating at a steady pace. We're going to recheck the TSH every 4 to 6 weeks to fine-tune the dose. No guessing games here when it comes to that Synthroid. It's such a finicky drug. Pro tip, patients need to take Synthroid first thing in the morning on an empty stomach. No coffee, no breakfast, just vibes and water. People with hypothyroidism, basically adorable sloths, slow, sleepy, chilly, but we love them anyway. If you have a patient that comes in after you started them on a regimen for their hypothyroid with Synthroid, and they're telling you that they're having palpitations and sweats, you always want to ask them, are they taking their medication the way that they're supposed to? So are they taking it in the morning or on an empty stomach? Are they doubling up because they missed doses? Are they taking it with their other meds? Medication adherence is going to be the biggest reason why people revert to hyperthyroid symptoms versus hypo. All right, guys, now let's talk about hyperthyroidism. In hyperthyroidism, the thyroid hormones are in overdrive. Your metabolism is sprinting when it should be strolling. The usual suspect for hyperthyroidism is going to be Graves' disease. It's an autoimmune overachiever that tricks the thyroid into going full throttle. Classic signs are going to be rapid heart rate, anxiety, unexplained weight loss, lid lag, and exophthalmos. Yep, those bulging eyes are typically going to be a giveaway. Treatment is going to be radioactive iodine to calm things down, surgery to take the source out, or Tapazole or PTU to shut off the hormone factory. Tapazole is going to be used for most people, so it's known as Tapazole or methimazole, and PTU is typically going to be used in those pregnant patients only because it has a low medication adherence. So pregnant patients will typically take this in the first trimester, and then they can switch over to Tapazole. We can add a beta blocker like propranolol to the mix to put a brakes on the heart pounding symptoms. We're going to watch out for thyroid storm, a full-blown hormone hurricane with high fever, tachycardia, and chaos. It's a medical emergency, and these people need to be referred to the ED. Okay, let's do diabetes now, guys. So diabetes is going to be a long-term condition where your body flunks at its job at managing the blood sugar. So either your body's not making insulin or you're not using it right. So as we know, there are two types of diabetes. We have type 1, where your pancreas is on strike. You're not going to produce any insulin, okay? And then we have type 2, insulin's around, but your body's just not using it. So the classic 3 Ps that we look for when we're trying to diagnose somebody with diabetes is going to be polyuria, where you just can't stop peeing, you're peeing like it's no tomorrow. Polydipsia, which you're always thirsty, and polyphagia, so hungry like a teen on a growth spurt. You can't keep enough food in the house, you're so hungry. Diagnosis for diabetes is going to be the A1C. Typically, that's her gold standard. And a positive A1C for diabetes is going to be an A1C anything greater than 6.5. Pre-diabetes is anywhere in that 5.7 to 6.4 range. We can also diagnose with a blood glucose over 200 with symptoms. So maybe they're diaphoretic or they have headaches, but it has to be with symptoms. So overall, diabetes is like this. Glucose is trying to get into the club, your cells, but the bouncer, which is insulin, either isn't there or now demands a VIP pass. Either way, your sugar gets stuck in the bloodstream and it's not on the dance floor. Diabetes isn't a set it and forget it deal. It's a complex, ever-evolving condition that needs regular TLC. TLC stands for testing, lifestyle tweaks, and care. The first line MVP in the treatment for diabetes is going to be metformin. But before prescribing, we need to check kidney function because a low GFR and metformin don't mix. The max daily dose for metformin is going to be 2,550 milligrams. If someone has a GFR less than 45, we need to start thinking about reducing that dose. And if they have a GFR less than 30, hard stop. We can't give them any more metformin. If a patient comes in and their A1C is climbing above 9, insulin might need to join the party. A starting dose for basal insulin is going to be anywhere between 0.1 to 0.3 units per kilogram per day. Slow and steady is going to win the race when we're starting people on insulin, okay, guys? Heads up, long-term metformin use can sneak into a vitamin B12 deficiency, so keep an eye on those B12 levels as well with our diabetics, okay? We need to check on progress every 3 months for our A1C and to see how our diabetes management is going until those sweet goals are reached. Okay, remember, diabetes is very sneaky. Even when things seem under control, surprises can pop up. So stay flexible, stay curious, and stay checking those levels. Okay, metformin is our go-to for type 2 diabetes management. There's no risk of hypoglycemia typically. It's weight neutral and it's generally a low drama kind of drug. The next kind of drugs that we'll look at are our SGLT2 inhibitors or the flozins. These medications help you pee out the sugar and come out with a cardioprotective bonus. Watch out for unwanted plus ones like UTIs and yeast infections when putting patients on these meds. The next meds that we'll talk about are our DPP-4 inhibitors or the leptins. They're easygoing unless your patient has a history of pancreatitis. In that case, this is going to be a hard pass. Now we'll talk about our sulfonylureas or the IDEs. These are old school charmers but have a high risk of hypoglycemia, especially in the elderly, so proceed with cautions. And then we have our thiazides or our glitazones. These help you with insulin sensitivity, but they're a no-go on our heart failure patients, and you'll want to keep the tabs on their liver function, okay? And then lastly, our GLP-1s. These are the weight loss friendly option, but steer clear if your patient has a history of thyroid cancer lurking in the background. Bottom line, choosing diabetes meds is like dating. You might have to try a few before finding the best one, and sometimes a combo works better for some patients. Timing is everything when it comes to insulin. Get it wrong and it's a blood sugar roller coaster. This chart breaks down the onset, peak, and duration of different insulin types, aka your choreography for blood sugar balance. Rapid acting insulins like Lispro start quickly and they peak within 1 hour and they're gone in about 2 to 4 hours. So think of this as a sprinter. Short acting insulin starts in 30 to 60 minutes, peaks in 2 to 4 hours, and it lasts 6 to 4 hours, your classic slow but steady type. Intermediate insulin or NPH onsets in 1 to 2 hours, peaks hard at 6 to 12 hours, and it lasts about a full day, 24 hours. This one loves a dramatic entrance and a long stay. Long-acting insulin or Lantus shows up in about 2 hours, has no peak, and hangs out for a smooth 24 hours. The chill one of the bunch, we can say. Memorizing insulin profiles is like learning dance step. Nailed timing equals graceful glucose control. Bad timing means you're stepping on toes and you're dropping blood sugars. Diabetes doesn't just mess with blood sugar either. It's an equal opportunity troublemaker hitting everything from your eyes to toes to your heart. So for eyes, we're going to want to make sure that we're doing annual dilated eye exams to help catch retinopathy before vision takes a hit. With our kidneys, we're going to keep tabs on urine microalbumin, BUN, creatinine, and GFR to catch nephropathy before it sneaks up. Feet and nerves, don't skip the neuropathy checks and yearly podiatry visits because unnoticed foot injuries can turn into serious problems. Heart and vessels, microvascular complications like CAD, PAD, and stroke mean blood pressure control is a must. We want to aim for blood pressure under 130/80 to keep things in check. Shots. The vaccine kind. Stay current on your flu, Hep B, and pneumococcal and Tdap because infections hit harder with patients with diabetes. Bottom line, diabetes complications are sneaky, so comprehensive routine screening is going to be our best defense. Catch it early and manage it better. Okay, guys, now let's talk about metabolic syndrome. So metabolic syndrome is going to be a cluster of risk factors tied to insulin resistance and abnormal fat metabolism. So these are going to leave patients with an increased risk for type 2 diabetes, cardiovascular disease, fatty liver, and some cancers. So diagnoses are going to need 3 out of the following 5 criteria: a fasting glucose greater than 100 or on diabetes mellitus meds, a blood pressure above 130/85 or on meds for hypertension, triglycerides above 150, HDL above 40 in men and above 50 in women, and a waist circumference above 40 in men and 35 inches in women. And for Asians, they get a little tweak, a waist circumference over 35 in men and 32 in women. The signs are going to be patients that are having issues with hypertension, hyperglycemia, high triglycerides, or low HDL, abdominal obesity as well. Management for these patients is going to be lifestyle changes such as diet, exercise, and weight loss. They need to have good control on their blood pressure meds, hyperlipidemia meds, and glucose medications, and they need to be referred to a nutritionist as needed. Let's talk about some high-yield red flags for our boards. Endocrine emergencies like Addison crisis, thyroid storm, and myxedema coma aren't just dramatic, they're board exam gold. Let's know how to spot them and stop them. So screening for diabetes, we need to stick to the basics like our hemoglobin A1C. Anything over 6.5 is going to be indicative of diabetes. For these patients, we want to make sure that we're checking that urine microalbumin. Don't let these silent complications sneak by. We want to be smart with our diabetes medications because boards love to test these pitfalls. For our SGLT2 inhibitors or our leptins, these are not going to be for patients who are incontinent unless you enjoy managing endless UTIs. Our thiazides are a no-go in our heart failure patients because fluid overload is real. In our sulfonylureas, in the elderly, we need to look for fall risk because these patients are going to have an increased fall risk due to hypoglycemia, so tread lightly with that pair. Metformin, we always want to check kidney function. Don't invite lactic acidosis to the party. Now, let's talk about some endocrine clinical pearls that are not about diabetes that you guys must know. Let's know that Cushing's is going to be increased cortisol, and those patients are going to have moon face, striae, and hypertension. We're going to want to check for a 24-hour urine cortisol and a dexamethasone suppression test to diagnose Cushing's. Now, for Addison's, on the other hand, Addison's is decreased cortisol, and those patients are going to have hyperpigmentation, hypotension, and salt cravings. A Addison crisis is an emergency that needs to be treated for steroids. So if you have a patient or you have a question about a patient that you think has Addison's, we're sending them to the ED. That's not something that we can typically manage in a primary care setting. Pheochromocytoma, those patients are going to have episodic headaches, sweating, and hypertension. For diagnosis, they're going to need urine catecholamines or plasma metanephrines. Let's talk a little bit about hypo versus hyperthyroidism. Hypothyroidism is going to be increased TSH One more time, increased TSH and decreased T3, T4. Those patients will have symptoms like fatigue and weight gain. We want to start Synthroid if our TSH is above 10, and with patients we want to go low and slow. For hyperthyroidism or Graves' disease, we're going to have decreased TSH. Once again, decreased TSH. One more time, decreased TSH and increased T3, T4. These patients will present with tremors, weight loss, and usually exophthalmos, which is those bulging eyes. The treatment is going to be radioactive iodine, tapazole, and beta blockers for symptom management. We can also use PTU for pregnant patients in their first trimester. Parathyroid is going to have increased calcium. We always want to check for malignancy if we have increased calcium to make sure there's no bone leaching or anything from cancer. For metabolic syndrome, look for the 3 out of those 5 of the criteria that we listed earlier. In type 1 diabetes, those patients need insulin only, but they will be at an increased risk for diabetic ketoacidosis. Type 2 diabetics, we typically want to start with metformin. And if the A1C is above 9, then we will give insulin. Yearly diabetic screenings are going to be for those eyes, feet, kidneys, blood pressures, and remember, shots. We want to make sure those patients are getting their vaccines. A little more pearls before I send you guys on your way. When in doubt, refer it out. Endocrine zebras like Cushing's, Addison's, or Pheochromocytomas, don't hesitate to loop in the endocrinologist. We always want to do labs before imaging. Always start with labs. Hormones don't always show up on CT scans, but they'll spill their secrets in the blood work. Remember, for medication management, start low and go slow, especially true when prescribing Synthroid to elderly patients. No need to shock the symptoms. Timing matters. We want to give steroids in the morning to mimic cortisol rhythm, and we also want our adrenal glands to be thankful for us in this process. Metformin, we want to make sure that we check our B12 because that long-term use can drain B12 stores, so stay ahead of it with routine checks. I hope that these slides were helpful to you all. I hope that you're listening to them on your way to your clinical so you can look like a bad ASS in your clinical and look like you know what you're talking about. Or if you're getting ready to take your boards, I hope that this was helpful to you. And I hope that you were able to pair it with my guide. And I hope that you pass your boards if you're about to take them soon. Let's do some practice questions to see how much we've learned from these slides. Question number 1. A 45-year-old female presents with fatigue, weight gain, and cold intolerance. Her labs show a TSH of 12.0 and a free T4 of 0.4. What is our next step? Is it number 1, start Synthroid 50 micrograms daily? Step 2, order a thyroid ultrasound? Number 3, check anti-TPO antibodies? Or number 4, refer to endo? I'll give you guys a few seconds to think about your answer. Okay, our answer is going to be A. With overt hypothyroidism, she has a TSH above 10. We're going to initiate Synthroid therapy. So she's probably already had a TSH and it was above 10. Whatever they don't give us, we kind of assume. And so now this is our repeat with a T4. And these labs are pointing to hypothyroidism. So we're going to treat with Synthroid. Question number 2. A 32-year-old male with type 1 diabetes presents with nausea, vomiting, and abdominal pain. He has a blood glucose of 450. What is the most likely diagnosis? Is it number 1, HHS, number 2, diabetic ketoacidosis, number 3, lactic acidosis, or number 4, acute pancreatitis? I'll give you guys a few seconds to think about the answer. The answer is going to be B, diabetic ketoacidosis. Type 1 diabetics with high blood glucose and symptoms is going to suggest DKA. Okay, guys, I hope this was helpful to you guys. Remember to stay balanced and stay brilliant. Thanks for joining me on this hormone-filled roller coaster. I hope you found this info helpful, engaging, and maybe even a little fun. Remember, endocrinology is all about balance, kind of like life, but with more lab work and fewer crystals. Let's stay connected. I want you guys to follow me on Instagram and TikTok if you're not already at One Trap Nurse, or you can shoot me an email at kenyabrown@adventurenursing.com. I'm always happy to help and answer any questions that you guys might have. This is my first video that I'm putting out on YouTube, so please just let me know if you guys like it. Thank you again for your time, your attention, and your curiosity. Wishing you all the success and sanity on your nursing journey.